got another brilliant presentation, and Tony so eloquently sort of, I suppose, taken, look at May's presentation, but actually bringing us to the reality behind that, the people, the lives, the misery that happened. And I definitely, for one, would be, very interested in supporting an Irish AIDS memorial. So thanks again for that, Tony, and well done. We have one final presentation. I think there's going to be two people presenting, and we have Caroline Gardner of Quality Matters and our colleague Robert O'Donoghue, and they are going to present the National HIV Survey findings. So thank you, Caroline and Robert.
Hey there, everybody. A little time check just before we start, is we're running a tiny bit late, and you guys have a break, which I'm sure you're really looking forward to. So can I propose something? We have a half an hour presentation and about 20 minutes to do it in. So I'm going to give it to a vote to you guys at some point. You've got a 25-minute break. So what I'm going to propose is that we go kind of 5 minutes into that, and then you get to decide whether we get another 5 minutes, whether you want to hear kind of the last bits of that data. And of course, we all love data. But this is important data because it really picks up from what Maeve was talking about the history and how we have to learn from that and bring it to the past. And then some of Tony's words really struck me, which is, we're now dealing with the residues and echoes of stigma. And so the survey that we're going to present really talks about and tries to understand, well, what are those residues? What are those echoes? What does stigma look like in today? And I just want to say as well, from a presenter's point of view, there's never two speakers who I would be more happy to give my time to than Maeve and Tony, because it was an amazing setup for the day. So thanks very much for that. So these two surveys were commissioned by HIV Ireland. And we're a social research charity called Quality Matters. We were very grateful to receive the commission to undertake this work with a steering group who I'll talk about. Because we exist to help policymaking be data-driven, to help policymaking include the voices of those affected by it. And this project very much speaks to those values. So let's have a look. So what I'm going to be talking about is a little bit about what we know about stigma now, I guess, from the literature and research. Rob's then going to be looking at a survey that was done with the whole population of Ireland. So obviously that wasn't the whole population, it was around 1,000 people. But that's a really significant piece of work to look at and say, well, what are those residues? What do they look like in the whole population now? We then did a piece of research with 168 people living with HIV. So I'm going to be presenting on the findings. What is it like to live, and how does that affect people's lives? We're then going to be looking at 6 key findings from that. So what do we know? We've heard the term stigma a lot of times, so we all innately know it, we use it in our common language. And essentially it's the devaluation of people. I quite like this definition though, because I think it does really drive home what stigma does. It's also a mark of disgrace that sets people apart from one another. And we're going to hear that theme picked up a lot through this. If we look a little bit more at the theory of stigma, it's often broken into 3 different types. And the research we're going to be showing you is going to speak and provide a bit of information around each of these types of stigma as they exist today. So the first is enacted stigma. This means something that actually happens to somebody. Rejection, isolation. I quite like the way this is described by Bunn, which is micro insults and daily hassles or macro aggressions. And what we're going to be looking at is a range of behaviours, from someone being insulted, excluded, right up to someone having a violent act upon them. So some really, really serious, and they all have very serious ramifications on people's lives. Perceived stigma is the fear of these things happening. And we're going to see again and again a pattern in the data whereby twice as many people as something happened to fear it happening. And one of the big reasons for that, says the literature, is that people don't talk about it. And we've heard this said from Tony, from others, is that the best way to avoid stigma is not to tell people. Internalized stigma then. the most harmful, is when that hate or that devaluation that's happening in the world then turns inward. So the impact of stigma, and most of us are going to be pretty knowledgeable about some of this stuff, is that there's a big body of research that proves that stigma increases isolation and it lowers self-esteem. And internalized stigma has been shown to have a worse impact than what's happening out there. And so this is a really important point when we look at policy and responses. Internalized stigma is associated with depression, anxiety, and hopelessness. And a person with an HIV diagnosis is 10 times more likely to develop depressive symptoms in comparison to the general population. That's in red. So remember that, because we're going to come back to this when we look at the Irish data, and it contextualizes some of these findings, I think, in very, very serious ways. Okay, so the impact is for individuals and society. We understand very inherently that, of course, all of this stuff, this devaluation, it lowers people's quality of life, and that's extremely important. But it also affects treatment in ways that might not be so innately understandable. So there's a good body of research, and a growing body of research, that says it actually affects the way it affects the way that impact is operating, and it also affects the way that people are adhering to treatment regimes. So it has both a personal quality of life and also a medical implication. And then for society, the fear of prejudice and stigma is stopping people from getting tested, and we're going to look at the data around that, and what that's going to show is that this is still very real in Ireland. Okay, so policymakers are acknowledging that stigma is very, very important, and it has to be a part of any country's response to this. And eliminating stigma is Target 8 of the UN Political Declaration on HIV and AIDS, which Ireland has signed up to. Now, one of the indicators that that's being done is that stigma is being measured. So this study here, the first since 2007, and a very sizable one, undertaken by HIV Ireland, is providing a real platform for Ireland to start saying, look, we are doing this. Now, of course, after this, something needs to be done with that data, but this is a really important first step that's recognised internationally in that fight against stigma. Okay, so my colleague Rob now is going to introduce you to some of the findings from that whole population study on society's attitudes to stigma.
Hey everybody. I'm going to run you through the findings from the first survey, which was the general population survey on transmission routes of HIV and attitudes in the general population towards people living with HIV. So after getting ethical approval from the Mater Hospital, we took the public knowledge and attitudes questionnaire from the National AIDS Trust in London, and we adapted it for the Irish population. We had it disseminated by a company called MD Research in an omnibus survey, which is a marketing research tool to gather large volumes of data. The sample was randomized. There was just over 1,000 participants. They were over 18, and they all lived within the Irish Republic. Now, it was stratified also by gender, age, and the location where the person lived in the country to try and get as representative a sample of the Irish population as we could possibly get. And the margin of error was 3.2%. That just means that if we were to run this survey again, like 1,000 times, on average it would come out that the results that we got would be plus or minus 2.3% in either direction. And we were able to compare to the English data to see internationally where Ireland would stand. So what do we find? As far as transmission of HIV is concerned, we found that there's generally good knowledge of transmission routes in the Irish population. For example, Irish people were able to tell us, about 95% approximately, were able to tell us that unprotected sex between a man and a man, between a man and a woman, and by sharing needles were route for the transmission of HIV. However, we also found that there was common myths still existed about transmission of HIV. And so you can see in the highlighted in the graphs on the left-hand side, as the Minister said earlier, 70% of people think that you can get HIV from a bite. Now, technically that may be possible, but there's no documented case of that ever happening in Ireland, and it would have to be extenuating circumstances. Further down, 24% of people believe that you can contract HIV through kissing, 10% through sharing a glass, 11% through coughing and sneezing, and 9% through sharing a public toilet seat. And now, as Maeve said earlier, as well as, and other people highlighted as being an interesting point, 56% of Irish people that responded replied that through a blood transfusion in Ireland it is possible to get HIV, which, as we screen for HIV in the National Blood Service, it is not. So when we drilled down into this data, we found that younger people have larger knowledge gaps or misinformation about transmission of HIV. We found that 2 out of 10 18 to 24-year-olds replied that it was possible to contract HIV from sitting on a public toilet seat, compared to 10% across older age groups. And we found that almost 2 in 10 18 to 24-year-olds believed that it was possible to contract HIV through coughing and sneezing, compared to 13% across the older age groups. And this was also highlighted by some people who read the report, or early versions of the report, as an important point on transmission. Only 19% of respondents were able to correctly respond that the risk of someone taking effective HIV treatment passing on HIV was extremely low. So, as I think Caroline said earlier, like, care and treatment for HIV has come on leaps and bounds in the last 20 years, but that statistic suggests that it's not filtering down into the general population anyway. So, attitudes. What we found in general, again with attitudes, is that Irish people generally have non-stigmatizing attitudes towards people living with HIV. So 83% of people believe that someone living with HIV deserves the same respect as someone living with cancer. And I think it was Tony that mentioned that there should be better education in schools. Well, 93% of people believe that young people should be taught about HIV in schools so they understand the condition for when they leave. Only 2% disagreed with that. I know that doesn't add to 100, but the other two categories were didn't know, or didn't agree or disagree. Again, we found there is differences in age categories and people's attitudes to people living with HIV. For example, the same people found out, if people found out their neighbour was living with HIV, 70% of people said that they would not change their relationship with them. And this was similar numbers for a work colleague. However, about 15% for those two questions also said that disagreed with that statement, so it implied that it would change their relationship with them, which points towards like a small minority or a minority of people who do hold stigmatizing attitudes. And again, 72% of people said that that if they found out a family member was living with HIV, that they wouldn't change their relationship with them also. Again, this was bigger in the younger population than in the older population. I think 77% of people, 18 to 24, agreed with this, whereas just over 70 for the older age groups did. Okay, so in comparison to the UK, we found that generally Irish and English attitudes and knowledge of transmission rates were similar. The attitudes in particular that only fluctuated by maybe 3 to 4%, like on any of the attitude questions that we asked. And there was a slight difference in knowledge of transmission rates. Irish people were more likely by about approximately 15% to respond that that HIV could be transmitted by sex between two men, by a man and a woman, and by sharing needles. However, Irish people are also more likely to incorrectly state that HIV is transmissible through spitting, coughing, sharing a public toilet seat, and kissing. So, to sum up what we found in the general population survey, knowledge of transmission rates within the Irish population is good, but there is room for improvement. Young people are more likely to have gaps in their knowledge or misinformation about how HIV is transmitted, and they're also more likely to be more accepting of people who are living with HIV than older age groups. Though Irish people tend to have non-stigmatizing attitudes towards people living with HIV, there is a minority there that still do hold stigmatizing attitudes. And the figures between Ireland and the UK are broadly similar in our attitudes and knowledge of transmission rates. Okay. Thank you for listening to me. I'll pass you back to Caroline.
Okay, so next what we did is we looked at the experience from the perspective of people living with HIV. And to do that, we worked with a steering group, and on that steering group was Niall, Susan and Erin from HIV Ireland, Sandy from POSNOW, who's in the audience today, Paddy and Alan from the Mater Hospital, and Patrick from TCD, who will be speaking later on today. We looked at the research that had been done and we formulated a draft survey. But what we did next was the most important thing, which was we took that survey into a co-design space with people who have HIV. So what that means is rather than asking them about their experiences and then as researchers deciding what we were going to do with that, we let them take our draft survey and pull it apart and put it back together again. It was the most worthwhile activity that we undertook in the research, because the research was massively improved because of that view. Every question but 3 was changed from our draft survey. As we go through, I'm going to point out when the focus group added something to it or said, look, you really need to look into that. And some of the most, I think, important findings come from that perspective. After we had the survey done, we got it out as far and wide, in line with a very robust set of ethical guidelines which the Mater Hospital had approved to make sure that this in no way made anyone feel like they had to do it and that confidentiality was protected at all times. So it went out through a number of social services and they're all named in the report. So thanks very much to those that are in the room. It went out on social media. And Susan did a huge amount of work getting that out on HIV Ireland's very popular, very present social media for all of us that have their messaging coming up on our phones all the time. And of course, posters and other methods. So we were really glad that we got 168 people engaging with that and opting in to share their views. So I'm going to go through those now. But before I do that, let's look at who completed the survey. Given we're a bit short on time, I might not actually go through all of these. But I think some of the more important points are that approximately, the very last point here, approximately 1/3 were diagnosed in the last 4 years, and then between 5 and 10, and then 11 plus. So it was getting a broad range of people's experience in that journey of actually experiencing life post-diagnosis. The other, you see there's a little star there next to the single one. That's because I'm going to point that out as we look at some of the other findings. So 54% of that population was single. Most of them were 52% were living in Dublin. Okay, so let's get into the most interesting part, the views that people told us. So 35% of respondents agreed that some people do not want to associate with them because they are living with HIV, and 88% agreed that some people think living with HIV is shameful. So that 15% that Rob talked about, the 15% of the population who still hold stigmatizing views, that hasn't gone unnoticed. It has been picked up by people living with HIV, and it is known, it's understood, it's affecting people, and we're going to see some of those effects. 61% of people are comfortable with their HIV status. The 26 who are not are more likely to be diagnosed in the recent past. So this does point to the fact that as people move through their experience post-diagnosis, they become more comfortable with that. And I think that points out an interesting thing as well as looking at policy and what can be done. What are those support services? And Catherine was talking about that in her own presentation. Okay, so first let's start looking at perceived stigma. So this is the fear of things happening. And you can see in that first kind of lot of red arrows, we have the things that people most fear. And that's around 50% of the population we spoke to, we surveyed. Fear being rejected in a personal relationship, being gossiped about, or being outed. And we're gonna dig a little bit into that notion of being outed. Next down, we see between 20 and kind of around 20 to 30% then, fear being excluded from social gatherings, being verbally insulted, being physically harassed or threatened. Only 1 in 5 had no fear of stigmatization. So if you look around the room, if we take the first, I've kind of done a rough count, if we take those first 3 lines out, everybody else in the room, if you all were HIV positive, would be fearful, living with a fear in the last year of some form of stigmatization. So there's not too many people who aren't affected by this. So let's now look at the experience that people have around these stigmatizing behaviors. But first, before I do that, I just want to point out a pattern in the data, because researchers like patterns in data. See here, there's an angle. You can see it goes from very small to very big. That's the same angle as you see here. So we're looking at the same things. And again and again, in every single area, what we're seeing is that almost twice as many people as fear something happening to them. Am I saying that the right way? Of those people that stigmatizing experience happens to, twice as many fear it happening to. So you can see that kind of shadow effect. We can also understand then that maybe it's not happening as much as that because people are not disclosing, and we'll look at that issue of disclosure as well. Okay, so from this data we can see kind of between a quarter to 30% in the last year have had the following experiences: being rejected in a personal relationship, being gossiped about, or being outed. The next block down then is kind of between 10 and 15%, so quite a sizable amount of people in the population have been verbally insulted, harassed or threatened, been excluded from social gatherings or activities, and been physically harassed or threatened. The last one is people who have been physically insulted. Now that number, when you look at it in comparison to the others, seems quite small at 5%, but that relates to 8 people. And I think sometimes, when we look at a whole lot of numbers on a chart, we lose a bit of the humanity. So if we think of each of those 8 people as being one of the blocks on the quilt, I think it drives home the ramifications of this, is that this is very real and it's very serious. So let's look at the one that was at the top of that chart. That's rejection and isolation. So that's the one that most people fear happening to them. It's also the thing that happened to the most people. So 61% of all those we spoke to feared it happening, and then 32% it happened to. And this was a big issue for people in the survey. We had lots of comments talking about the human effect of being rejected. Here's one quote. "It can leave you lonely and it's very hard to discuss with some people. I blame it for the fact that I'm single and I worry about old age. An odd thing for someone my young age." And we saw that theme coming up a little bit, the difficulty of forming intimate relationships, the loneliness that came from that. And again, this is the second time you've seen this bit of data, but 35% of respondents felt that some people don't want to associate with them because they're HIV. So disclosure, it's the main means that people have of preventing stigma on a personal level. And 61% of people chose to exercise that and not disclose to somebody because they were afraid of being judged or treated differently. 83% had not disclosed their status to a neighbour, and 76% had not disclosed to work colleagues. Now, because that data's up there, it doesn't imply that disclosure is a positive, so this is a bad thing, but it does highlight people's choices. And I think it does so with an acknowledgement of that mirroring of the coin, because we saw before what neighbours and colleagues think, and we know that 15% more or less in those groups do hold stigmatising views. So why are people disclosing when they choose to? Well, you can see, if we look at the top 5 bars there, they're disclosing because they trust people and they want to share information, because they want to make sure others are safe, They want a better service or treatment. They want to be themselves, or they want to challenge discrimination. And I think this really echoes what our earlier speakers this morning, from Catherine onwards, were saying, is that there's a great desire to be an individual in the world and to be acknowledged in that way. But the issue of disclosure isn't simple, as many of us know, and the research also highlighted that. So I'd like to read this one quote, which I think puts it very well. "There is a fear of people judging you and a fear of being rejected, even when your direct experiences haven't justified that fear. Entering a relationship or even engaging in a casual sexual relationship is fraught with anxieties over whether or when to disclose. You must weigh up your right to medical confidentiality and privacy against the right to be treated with honesty." So it's by no means a simple decision. And I think that point makes the next few points even more stark. That's third-party disclosure, when that decision is taken away from somebody and it's disclosed on their behalf. So 55% of respondents feared this happening to them. 26% experienced it. Most notably, though, and this is something that was the focus group wanted to ask about because it had been an experience within that group, and I'll talk about a little bit about that experience, is they wanted to know how often this is happening in a health setting. And 18% of people reported that they had had their HIV status accidentally disclosed in a health setting. And I can see some heads nodding in the audience, which was the exact reaction when we read the research and when the steering group looked at it. In the focus group, one woman spoke about this experience, and she did so with a great deal of empathy for the nurse who had made the accidental disclosure. She understood that nurse was really, really busy, and that nurse was rushing between person to person. And she empathized with the fact that the nurse has accidentally spoken to her about information that when her family member was standing there, then said, "Have you got HIV?" as soon as the nurse left. So she understood the position of that nurse and that she had done it accidentally. But that accidental disclosure had profound effects on her life. There were very definite reasons why she had not disclosed to her family. And those reasons, of course, related to stigma and how they'd perceive it. But that decision was taken away from her, and it had a really huge impact on her life. Now, in research terms, the next thing I'm about to say, there were only 8 people who said this, but proportionally, African respondents were around twice as likely than other nationalities to report being outed by a third party. So this possibly begs further research or further investigation to see what that means. Is this an issue of layered discrimination? Are there other things going on here? Oh, is it 10 past? Okay, I've taken the time I said. Can I have another few minutes to finish? I'll try and rattle through this. Sorry, guys. Okay, offensive language. Again, the focus group wanted to know about this. So you can see on the chart that people are saying, yes, that the information out there is quite offensive. The use of clean and dirty on dating apps was a huge issue for people. 25 people raised that and said, this is awful. It makes us feel really terrible. It's a really, really big issue. And radio stations, how they're using poorly understood research and sensationalizing issues was also considered a big issue. And of course, at the moment, I guess that has big echoes for us with what's been happening in the media. So who stigmatizes? Immediate family, health professionals and friends. They're the people who most often know about somebody's status. But what jumped out for us was the bit in the middle, health professionals, because while the other 2 are family and friends, they're going to have their own processing. We don't quite allow that for health professionals who are being paid and who we expect a professional and human rights informed service from. Layered stigma is a big issue, and we've heard both Maeve and Tony talking about that. The research shows that people still think this is very much an issue. There is good and bad ways to contract HIV. 18% also considered it more stigmatizing than other forms to have contracted HIV through sexual violence. And it was interesting to follow on from some of Tony's comments this morning. And again, this is something that the focus group wanted to be included. It wasn't something we'd thought about, and it's not something that you're seeing a whole lot in the literature. So again, this is a notion that may be really benefit from being looked at into the future. Around 60% of the total population reported experiencing some form of layered discrimination. So whether that was because of their sexual orientation, being a member of a minority group, or an injecting drug user, that affected many, many people. Okay, here's one of the biggest findings from many people's perspective, which is that 17% of people felt suicidal in the last year. That's a really stark number, I'm sure you'll agree. In Ireland, we don't have a comparative piece of information to the whole population, but in America, where they do ask that question, they do have that information, a comparator is potentially between 3 and 4%. So you can see that's many, many times higher, 4 times higher. So stigma impacts people in many, many ways, and you'll see lowered self-esteem, fear of the future, shame, anger, and fear are all up there. It also affects people's life choices around being able to travel, get insurance, mortgage. And of course, some of these are complex issues where it's not stigma alone that is having an interplay, but it does speak to the experience of being HIV positive and how it limits choices in different things. The research shows that it does have an impact on whether people decide to get tested. That figure below says that 38% said that fears about how people would respond made them hesitate to get tested. So at the moment when we see HIV rates increasing, this is a very, very stark figure indeed, and it has significant implications for policy making. So the focus group again, and I'm almost there guys, I've got a couple more slides. The focus group again, they said, look, you've forgotten something really important, is that while getting an HIV diagnosis can be extremely traumatic, it can be an extremely difficult experience, that journey is not defined only by negatives, it also has a lot of positives. And so ask about that. And so the research says indeed there are positives that come from that journey. Meeting people, being supported people, and then supporting people. Around half are talking about that sense of community, that sense of reaching out, and then the sense of being supported as being, really significant positive events in someone's life. 57% of people also said that they feel more open-minded and compassionate as a result of their diagnosis. It's a nice slide, isn't it? So what are the big 6 findings from this? The first is that knowledge in the general population is good, but there is room for improvement. And young people know less. So the good work that's been done, and we argued about this as to whether when we looked at the data we could say that Ireland was broadly comparative to the UK, or whether it was slightly better. I was definitely plugging for slightly better. So it does show that most people have a good understanding of key transmission routes, and I think that as we look at all the literature around the room is a testament to what good work has been done in these areas. But young people do know less, and there's a call to ensure that that continues. 4 decades on from the AIDS crisis, HIV is still a reality. Those residues and echoes that Tony spoke about are still very much there. And they have a big impact on people, on their self-esteem. At its worst, 17% are thinking about suicide. The stigmatization of people in health services is a big issue there, especially the disclosure, which I'm sure is a figure that many people will walk away from the room with. I definitely did, and I know the steering group did as well. And then, lastly, on a positive note, HIV diagnosis brings challenges, but also opportunities. Thank you very much. The short report is down the back, and the long report is available on the HIV website. Thank you.
Thanks to Caroline and Robert for a fascinating presentation. I know you're all dying to have coffee. If you can hold any questions until the next session when there'll be a Q&A. And in the Minister's absence, I want to thank her for being here. She had to leave. Thanks very much to the presenters, to Tony and to Maeve. Go and have coffee. Go forth and drink. Thank you.